Hello and welcome to this latest panel discussion from the Underwood Center for Digestive Health at Houston Methodist Hospital. My name is Eamonn Quigley and I serve as co-director of the Underwood Center and also the David M. Underwood Chair of Medicine in Gastrointestinal Disorders. It's a great pleasure to welcome you to this roundtable discussion today, where we'll be discussing what is probably one of the hottest topics, not just in medicine, but in the media, namely GLP-1 agonists. There is a lot of interest in this area, quite a lot of dialogue, and no shortage of controversy. And I hope we will come up with all of those areas. And we want to speak particularly today about general aspects of GLP-1 agonists, but also what issues come up for the patient who's undergoing surgery or undergoing a procedure. So with me today is a panel of experts from Houston Methodist and MD Anderson, who've dedicated much academic and clinical time to this topic. So I'm going to ask each of them now to introduce themselves as we go around the room.
Hello, my name is Dr. Samaneh Dowlatshahi from Houston Methodist Hospital, Endocrinology Department.
And I'm Randy Steadman, the Carole Walter Looke Centennial Chair of Anesthesiology and Critical Care. And I am pleased that Dr. TJ Gan accepted our invite to join us from MD Anderson. TJ, can you give them your introduction and background?
Sure. Thank you, Randy, and delighted to be here. My name is TJ Gan. I'm a professor and head for the Division of Anesthesiology, Critical Care, and Pain Medicine at MD Anderson, just across the street.
And I'm Thomas McCarty. I'm a gastroenterologist, advanced endoscopist here at Houston Methodist, with specific interest in obesity medicine and endoscopic bariatric procedures.
Well, as I mentioned at the outset, I think everybody has heard of GLP-1 agonists, if not in their scientific terminology, certainly in terms of the many trade names, of which there are several. So before we start talking about some of the issues relating to surgery, and anesthesia and procedures, I'm going to ask our endocrinologist to talk to us about the background to these compounds, where they came from, what are they used for, and where do we see them going in the future?
Yes, absolutely. So GLP-1 receptors agonists were initially approved for treatment of type 2 diabetes, but their use were expanded for treatment of obesity management. And the reason for that was because of their effect on weight loss. Their mechanism of actions are through enhancing glucose-dependent insulin secretion, suppressing glucagon release, releasing hepatic glucose output, delaying gastric emptying, prolonging satiety, and reducing food intake. They also act on hypothalamus to suppress appetite. In terms of efficacy and side effect, their effect on diabetes control, they are able to lower hemoglobin A1C by 1 to 2%, with additional cardiovascular benefits. In terms of weight loss, semaglutide or Ozempic at a dose of 2.4 milligrams, which is the max dose of the medication, leads to an average 15% total body weight loss in persons with obesity. There is another medication in this group, tirzepatide, which is a newer medication, was recently approved by FDA. At a dose of 15 milligrams once a week, this medication is able to cause about 20% weight loss among obese individuals.
Obviously, these drugs have very widespread effects and have very dramatic effects. One of the things we're going to focus on today are the gastrointestinal effects, because they have become of some importance in relation to preoperative evaluation of patients and preparing patients for anesthesia. So, Dr. Steadman, would you like to comment on, from an anesthesiologist's point of view, what are the concerns around these drugs with regard to preparing the patient for surgery and anesthesia?
Well, as physicians realize and the general public realizes, there are time-honored standards that we hold to for fasting prior to surgery. And those have certainly been called into question when it comes to use of these GLP-1 agonists. There were reports that started appearing in the 2020, 2022, 2023 range of patients with solid food in their stomach, even though they followed normal fasting guidelines. And so those were of concern. And our society, the Anesthesia Society, the American Society of Anesthesiologists, then issued its first guidance in 2023 that suggested that these medications should be held for 24 hours if it was a daily medication and for a week if it was a weekly injectable medicine. And this was kind of the first guidance that we had for the anesthesia community on what to do with these drugs.
Dr. McCarty, one other issue that comes up in regard to preparing patients for endoscopy is, of course, preparation for colonoscopy. What impact do these drugs have on the patient who's being prepared for colonoscopy? Will they impair their preparation such that they may end up not having an incomplete examination?
Yeah, I think it's a great question. There's actually a meta-analysis that came out earlier this week that showed that there is a delay, it appears, with overall gastrointestinal emptying, not specific to stomach, but colon, small bowel, that shows that people on these types of drugs do typically or have a higher association with poor bowel preps or low quality bowel preps, leading to lower quality exams. I think the bigger question from an anesthesia perspective is that delay in gastric emptying specifically as it relates to aspiration the major concern? You know, with these drugs, 30 to 40% of individuals can have GI side effects. So that's diarrhea, nausea, vomiting, constipation. And so we don't yet know who is going to respond and how, which I think makes this a challenging topic. But I think that's why we are looking at high quality data and randomized controlled trial data to try to help us answer this question better.
Dr. Gan, in your experience, in your knowledge of the literature, what do you think are the risks for serious outcomes for these patients if they continue these drugs and go ahead and have an anesthesia?
Thanks for the question. Obviously, I think one of the major concerns for anesthesiologists is a risk of aspiration. I think the problem with aspiration is it's a rare event, estimated to be about maybe 1 in 5,000, 1 in 7,000 from elective surgery. So as a result, it's very difficult to study the incidence of aspiration. But we do know that GLP-1 agonists can and has been shown to reduce stomach emptying, and therefore there is a delayed gastric emptying, in particular solid. Recently, I actually reviewed a paper for British Journal of Anesthesia, which will be in press fairly soon. They looked at a 20 years period from 2020 to from 2000 to 2025. And they looked at using the FDA incident adverse event reporting system. And they found that of the 10 top drugs that cause aspiration, 5 out of 10 were actually GLP-1 agonists. And that considered about 50% of all the aspiration cases. So clearly, there is a concern. The question is, how do we triage patient in terms of being a low and a high risk? And that has been the main area of focus, how to manage these patients.
Dr. Steadman, I will have to declare that I am also a gastroenterologist. And of course, for our procedures, we're talking primarily about procedures that are done with propofol. So the patient is not intubated, but they're pretty deeply sedated. Is that a particular concern for you in relation to these drugs?
Yes, it is. So that would be, what we would call an unprotected airway. So propofol would decrease the gag reflex. And in a patient that already has potentially delayed gastric emptying, that would not be ideal. So with that 2023 guidance that my society put out, they recommended that if there was a concern and the drugs were not stopped as recommended, that then intubation and a rapid sequence induction in order to intubate was the proper course.
Now, Dr. McCarty, you've done some work in this area, and you came to a somewhat different conclusion.
Yeah, I will say it's a difficult, and I'm glad we're having this conversation today, because I would say there are some population-based studies with a large number of people that show there is a significant risk. Now, how much a significant risk when we're talking about 1 versus 3 and 10,000 patients is difficult to ascertain. But yeah, we just basically published a meta-analysis of randomized controlled trials, really designed to look at this specific question, right? What impact do these drugs have on gastric emptying? And to do that, we sort of reviewed the literature, and we found 15 studies total that sort of tried to answer this question. And again, using randomized controlled trials. So these are individuals who were on a GLP-1 or GLP-1 GIP receptor agonist compared to individuals who were not, so placebo. And what we found was that in terms of solid food, which Dr. Gan mentioned, there was a delay in gastric emptying, but only about 36 minutes. So really not clinically significant if we think about that 4 to 6 hour fasting period, which Dr. Steadman mentioned to or alluded to earlier. And then using the acetaminophen absorption test, which is a surrogate marker for liquid emptying, we found no significant difference in gastric emptying between those who are on the medicines and those who are not. So we always struggle with looking at population-based studies versus randomized controlled trial data, but I would say based on these randomized controlled trials, it appears that there doesn't appear to be a clinically significant increased risk, at least for gastric emptying in these individuals, which would potentially minimize the need to hold these medications 7 days before and the risk of aspiration. Though I know anecdotally, some of us may have some different opinions on that, and I look forward to getting into that.
So I want to go back to Dr. Dowlatshahi about diabetics. You're an endocrinologist, you look after a lot of people with diabetes. Given that they also are at risk for delayed gastric emptying, would they be particularly at risk if they're taking these medications?
In terms of diabetes management prior to the surgeries and these procedures, these medications are really, really useful to prevent from hyperglycemia. And discontinuation of these medications prior to these procedures can significantly increase the risk of hyperglycemia. Discontinuation, based on the new studies and new data coming in, might not be the best approach for patients who have type 2 diabetes. So maybe just discontinuation for everybody might not be the best approach, especially because we are working on new dosing of these medications. New medications are under process. For example, the patch forms are coming in, and we are hopeful that we can come up with the new doses of the medications at lower amount that can prevent from the risks for the patients to prevent from gastric emptying problems.
It's interesting that you say that, because just last week I had a gentleman who was on one of these medications, needed a colonoscopy, and there was no way he was going to stop because he'd spent a long time getting his diabetes under control, and he would prefer to take any risk rather than have his diabetes go out of control again. So I think that's a very important point about losing diabetic control as well. Now, Dr. Steadman, you and I have spoken about this on the phone. There are new guidelines. Would you like to update us on what the new guidelines are?
Yes, I'd be happy to. So I think some of the data that we just heard about and the concerns that we heard about led to then my society partnering with your societies, the American Gastroenterological Society and some of the bariatric societies, to come up with consensus guidelines. Again, these are not really what you would consider evidence-based because, as has already been pointed out, the incidence of aspiration is so low that you can't really get evidence on the incidence. But nonetheless, the consensus guidelines now take all of this into account and suggest that if you don't have any other reasons other than GLP-1 agonists to have delayed gastric emptying, that you can just be on clear liquids or liquid diet for 24 hours prior to the procedure and continue the medications throughout the peri-procedural timeframe.
And the liquid issue is very important, of course, because that relates again back to colonoscopy, because these people have to drink a lot of liquid for preparation of their colonoscopy. And if there was any issue with liquid emptying, which there doesn't appear to be, there would be a major problem. So, Dr. Gan, given these more recent guidelines, which obviously as a gastroenterologist we welcome, are there particular groups that you would identify that would still be a concern for you with regard to continuing their GLP-1 agonist before a surgical or endoscopic procedure?
Yeah, I think that's a good question. I think the key is really trying to identify some of the high risk factors. I think there have been a number of factors that have been, at least from the consensus, identified being high risk. For example, during the escalation phase of the treatment. And those who are in particular higher doses, or those who have symptoms of nausea and vomiting, as you pointed out earlier, that these drugs are associated with upper GI, nausea, vomiting. And also, I think those patients who exhibit delayed or slow gastric emptying, diabetic patient, for example, Parkinson's, and those any with delayed gastric emptying. And those are considered as a higher risk group that I think we need to pay more particular attention to.
Very good. So in that particular group, Dr. McCarty, would you go along with the idea of maybe doing intubation in some of those high-risk groups, or would you still be okay with going ahead with regular sedation?
I think it's a good question. I would say that I think what the new guidelines, which were from 2024, really focus on is a sort of a personalized approach and not a one-size-fits-all, which I think is key. And I would say for individuals, specifically with some underlying neurologic disorder or underlying gastric emptying delay already before these medications are started, if the patient is amenable to holding for a certain duration, I think that's probably the safest avenue to go. I will say we tried to address some of this in our study by doing a regression analysis, looking at whether types of treatment in terms of mechanism of action or type of specific GLP-1 agonists or certain medications like tirzepatide or semaglutide increase your risk. We didn't necessarily see that. There was no significant impact. Obesity in and of itself may be some factor in terms of solid food, but mild. But again, I think for individuals, especially for those prepping for colonoscopy who are on a liquid diet the day before, I think even regardless of their sort of underlying delay emptying, I think the risk is still very, very low overall. What do you guys think now that these medicines or one of these medicines is approved for obstructive sleep apnea? How does that play into the peri-procedural aspect in terms of your concern with, let's say, CPAP or obstructive sleep apnea and the risk of anesthesia with these drugs when one of these drugs is FDA approved to treat it?
Yeah, my sense is that, clearly with these drugs, there are risks and benefits. I think one needs to weigh the risk and the benefit. And then, as you mentioned earlier, that, there is a benefit of continue this drug to have a better diabetic control, in particular for sleep apnea. I think now, especially with the new advances in ultrasound technology, for example, those high-risk patients at MD Anderson, what we do is that we do a point-of-care ultrasound. And if the stomach is empty, based on ultrasound, give us some reassurance that we can put the patient under sedation for endoscopy, treat them just like normal patients. For those who have a full stomach, for example, or some volume in the stomach, then we can treat them differently in either doing a rapid sequence induction, as Dr. Steadman mentioned earlier, or perhaps if it is a routine case, maybe delay for a few hours before you do the surgery. I think that gives us some way to triage patient between high and low risk.
Dr. Steadman, are you enthusiastic about ultrasound in this context?
I think that's an area that has some technical and logistical issues, but yet some people are starting to do that. Not everyone can. I think most of us, our acute pain teams are probably the ones that have that expertise in point-of-care ultrasound. So it may not be everybody that can apply that, but I am seeing more and more articles that making it sound very appealing.
So going forward, I think we have reached quite a bit of consensus here. So what we're saying is that for an individual who otherwise doesn't have any risk factors, they're okay to continue with their GLP-1 agonist. But we should be looking out for factors that might increase their risk for delayed gastric emptying and therefore for aspiration, and then to treat those, as you said, Dr. McCarty, on a very individualized basis. One other issue that comes up is with the wide availability of these drugs, are there variations in their quality in terms of whether they're compounded or if they're available per prescription or over the counter or whatever? I know that you can get them at all sorts of strange places. So is that an issue?
So yes, these drugs are extremely popular and unfortunately expensive. And for that reason, there are many compounded form available. FDA has released a warning against the compounded form. The reason for that is some of the salt form being used inside the formula. So we don't recommend patients to start using them. And we believe that the side effects actually start to increase with the use of compounded form, including the gastric emptying delay.
Of course, it'll be more unpredictable as well, because you don't know the dose, you don't know exactly what's in them. So there's some very positive suggestions as to how we can help to avoid these complications. perhaps using ultrasound, point of care, which we do a lot of actually in GI here at Houston Methodist, to detect the patient who may have an empty stomach or a stomach full of food, and then a real important warning about compounded GLP-1 agonists. So if you've got a patient who's on a compounded GLP-1 agonist and is scheduled for surgery, should they be delayed or should they be evaluated differently?
No data. I don't think there's any data.
No data. But we should be aware of the possibility that the dose may be different or the quality may be different.
Probably because of the salt component inside it, it probably increases the delay in gastric function. It's very unpredictable, technically.
Yeah, I mean, even the new guidelines, which are the joint multidisciplinary guidelines, kind of say case-by-case basis. And one of the big things they do talk about is patient symptoms, right? So if the patient is having nausea, even if mild, maybe something to consider about concerns like point-of-care ultrasound, which is a unique aspect, or compounded sort of formulations.
And in fact, in the Department of Internal Medicine here at Methodist, the residents are being taught on point-of-care ultrasound. So these handheld ultrasound machines are around. So that's something maybe we should be looking at in our own department.
There was one study published that it takes probably over 30 exams to get good at gastric ultrasound for this purpose. So it's very different than learning ultrasound for nerve blocks or something else. So it's a skill that requires practice, but it's one that we could acquire.
We will be happy to teach you. Getting back to the endocrine issues, we've seen an explosion in use of these agents, and every day we seem to see a new indication. Where do you see these drugs going in the future? Will they continue to expand in terms of indications? Will we be giving them for all sorts of other indications? What do you see as the future here?
Yeah, they are definitely here, and they are here to stay. Their use are expanding definitely beyond the treatment of type 2 diabetes, all the way to treatment of cardiovascular disease, CKD, even neurodegenerative disorders, even addiction medicine. There are many different studies coming in that are going to be useful for addiction and alcoholism underway. Very interesting studies are coming in. The new doses and new formulas are also coming in. So we are expecting new medications in the form of orals, GLP-1, GLP-1s, glucagon, amylin to come soon. Inhalable forms also are coming soon. So very, very interesting future. We are expecting it to come soon.
Dr. McCarty, as we have you here, I cannot let you go without getting you to respond in terms of the future of weight management, because you've got a major interest in endoscopic approaches. And just last week at our very successful Underwood GI Symposium, we had some very interesting differing opinions about the benefits on the one hand of traditional weight loss and lifestyle management, use of GLP-1s on the other hand, use of surgery and use of endoscopic procedures. One of the criticisms of GLP-1 has been in terms of what weight you lose. Is it body fat, or is there too much lean body weight loss as well? So from your perspective, and you can be plenty biased here, from your perspective, where do you see your procedures fitting in terms of the overall management of people who are overweight or who have diabetes and are overweight?
Yeah, great question. I mean, I would say overall, I totally agree that these GLP-1 GIP receptor agonists are here to stay. I do acknowledge that a lot of the weight loss is non-discriminatory in the sense that you do find patients who, if you're not on a high protein diet or sort of doing resistance training, you're at significant risk for sarcopenia or lean muscle mass loss, which will have downstream consequences in the long term. But I think in the right patient population and with the right guidance, lifestyle modifications, including diet and exercise, is going to be the crux of everything we should be doing, right? And how do we sort of welcome in these new agents and present them more as a complementary treatment as opposed to a competitive, right? So previously in the past, we've had these silos of lifestyle, pharmacotherapy, and bariatric surgery. Endoscopic bariatric procedures, which is what I'm interested in and do a lot of here at Houston Methodist, I think is a unique aspect because it reaches a larger patient population, one of which the GLPs have done a tremendous job at sort of reaching. But obesity is a serious problem. It's an epidemic. It leads to a lot of downstream consequences that we in American medicine are good at treating, but we're not so good at treating obesity. And so I think combining these GLP receptor agonists with endoscopic approaches like endoscopic suturing, which is FDA approved, bariatric surgery, in combination with a multidisciplinary lifestyle approach is going to be key.
And what's very exciting is that there are individuals here at Houston Methodist who are involved in all of those areas and are now coming together to provide this multidisciplinary approach to the patient with obesity or with type 2 diabetes or with complications related to those. So I think we have a very exciting future ahead of us. With that, I'd like to thank all of you for a great discussion. I think we had quite a bit of consensus, a little bit of controversy, but at the end of the day, I hope you all found this very informative. Thank you very much.